Hello, everyone. Welcome. I think we are on and live. Please type in the chat if you can hear me, if everything's all good. And I did have to switch on subscribers only mode for chat. So we've had a couple bots recently, nothing crazy, but just to avoid that, you do have to be subscribed to the channel in order to type in the chat. So hopefully that doesn't bother too many of you, but I would love to hear from you. Today, we are talking about the 3 most commonly Googled questions that lead people to the QA Prep website. So if you don't know me, perhaps if you're watching this later, I'm Dr. Maelisa McCaffrey, founder of the free private practice paperwork crash course. And I have a website called QA Prep and Business. And when people are typing questions into Google about documentation, there are really common ones that show up that consistently lead people to my website. And 3 of them are the ones we're going to talk about. So they consistently kind of go through the rotation. And if you are able to type in the chat, go for it. Let me know you can hear me okay. Otherwise, we'll keep going. So we will dive into these 3 questions. And then if you are live and have a question about documentation, specifically about progress notes especially, then I am happy to answer your questions live on the chat so we can do continued Q&A. All right, so one of the most commonly asked questions that people Google is, can insurance companies request therapy notes? And the simple answer to that is yes. I mean, obviously they can request them, right? I think the real question there is, do I need to give insurance companies therapy notes if they request them, right? So why do insurance companies request therapy notes? Typically, it is because either there was no approval, and so each insurance company works a little differently, and so they want to review things before continuing approval for a service, or because some red flag popped up in their algorithm, and based on the billing habits, if you've been seeing someone for a while, that is a red flag, which doesn't mean you did anything wrong. It just means that it's something that's out of the norm, or what that insurance company considers to be out of the norm. And so they want to check up on things. So it's important to, number one, not freak out, don't panic. Number 2, it's important to then talk to your client. So the biggest issue for me around insurance companies having access to progress notes is client consent. So it's really important, as soon as a client asks you for a super bill, or as soon as you offer one, or even more so important if you are contracted with an insurance company and someone is using their insurance to pay for therapy right away, that you explain to people that, number one, you will have to provide them with a mental health diagnosis in order for therapy to be approved. And number 2, that insurance can request copies of their records to both check up on you and make sure that the services you're providing are accurate, and to make sure that they are necessary, medically necessary. And so really, it's not a matter of, it's one of those things that it just is, right? So we could argue whether it's right or wrong that insurance wants to do this, but the fact is that's what's happening. The key piece is that clients know it's happening, that it's possible, and that they are the ones who make the decision about that. These are their therapy records, it's their treatment, and they can choose to say, yeah, like, I'm totally fine with that. I want my insurance to pay for therapy. And if that means they might request records, that's fine. And then if the insurance company does request records, then you talk to them about it, let them know that you'll be releasing records to the insurance company, or ask them if that is okay. And a lot of the times clients will, say, sure, because I want my therapy to continue being paid for. And if they don't, then it's also important you let them know that insurance may choose not to pay for therapy anymore if they're not able to review that person's records. So again, we could, argue the morality of this issue. But that is the truth is that they can request the records, and if the records are refused, they can choose to stop paying for therapy. So, most important thing to take away from this is to let your clients know that is the case immediately when they start using insurance to pay for therapy, and have that in your documentation. And you can have a statement in your consent forms about how you cannot guarantee whether or not an insurance company will approve or deny services, which is a true statement, right? As much as you try, you have, and I do think you can have a lot of control over whether or not those services are approved based on how you document. But ultimately, it is a decision that an insurance company is going to make. So let your clients know that. All right. So the next most popular question I get is, how soon do therapy notes need to be completed? And the answer to this question is, it depends. And I laugh because that is commonly an answer to documentation questions, and it's a frustrating answer, I know. So I think there are one, maybe two states that actually do have laws around, meaning like in their laws around mental health documentation or around health documentation in general, that that you do have to enter notes within a certain time frame. That time frame is usually 24 to 48 hours. But it is extremely rare. Most states, provinces, whatever, do not have any guidelines around when documentation should be completed. There are some ethical guidelines that say it should be timely. So that phrase timely is often used when it comes to documentation. Obviously, timely is up for interpretation, right? So is that within 24 hours? Is that within a week? Is that within a month? Who knows? The other thing to consider is potentially your insurance contracts. So Medicare, Medicaid often do have requirements that notes are completed within a certain time frame, specifically Medicare. So that, again, is typically within a 24 to 48 hour time frame. So I say that, that 24 to 48 hour time frame, if you want to have something for yourself, or especially if you're like a group practice owner or a supervisor and you want to provide some guidelines for supervisees or employees, the 24 to 48 hour time frame is a good one to consider. The other reason for that, even if you are in solo private practice, to consider that kind of a time frame, is that it is really obvious on the auditor's end, like as someone who's reviewed a lot of progress notes, how long someone has waited to write a progress note. And no matter how awesome you assure me your memory is, it will be noticeable if your note was written within a day or so of the session versus if it was written a week or more later. It's just a fact that I've seen over and again. So that's why I do recommend that 24 to 48 hours. If your state does have a guideline, I can't remember off the top of my head which state, I think like it's one or two, which state it is that has that guideline, but then obviously follow that. None of the professional associations have a guideline for timeframes. Again, they just say timely and to do notes, basically. That's about as much guidance as they offer. So your insurance contracts are the most likely ones to actually have a requirement. And then if you are a part of some kind of practice to have that. I would say a good rule is at least within the same week. That is where you're less likely to then lose some of that information. And even if you take really good notes to yourself, you'll find when you go back, it just takes longer to write notes that are older. If you do notes within about that 48-hour time frame, it's a lot easier to write them. So that's what I would recommend. But for the most part, there is no guideline. And at what point are notes considered late? That's kind of another follow-up question I get a lot of the times. Again, it's really up for interpretation. So if you are documenting a later note and want to put late note, I would say a month is definitely late, in my mind. The kind of gray area for me is maybe after a week, between like week 1, 2, and 3. Is that a late note or not? I would say after 2 weeks, probably I would consider the note to be late, if you want to have some type of guideline for yourself. All right, we are breezing through these. So the last question, which is really, I never would have guessed this. These other two questions I get from people all the time when I do consultations, when I do trainings, things like that. This third question I never get ever. But I do get related questions. So we'll talk about that. So it's just so interesting that so many people type it in and then end up at the website. And that is how to document a patient crying. um, and the simple answer is to say, patient cried or client cried. That is the easiest way to do it. It's straightforward. It's a straightforward behavior. It is a very relevant symptom to document. So you don't need to provide a ton of explanation for it. And this goes back to a lot of what I talk about with documenting in your progress note what happened in the session. Just think about what's observable, what could be seen, heard, felt, all of these things, right? So if someone yelled, that is something that is often relevant to document and is very easily observed, right? If someone cried, if someone was wringing their hands because again, the interpretation of that might be that they're nervous, but the fact is that they were wringing their hands, right? So an interpretation of someone crying might be that they're upset or that they were depressed or sad, but the fact is that they cried. So rather than using kind of ambiguous terms or making assumptions about how someone was feeling or why they were doing something, unless you ask them why, often you might say, and that could be a very common thing. Someone starts tearing up, and maybe it's at a moment where you don't expect that to happen in therapy. You say, "What, what's going on for you right now? What's making you tear up? Why are you feeling tearful?" However you might phrase that. And that's a great conversation to have. And so you may or may not add that additional information. But the fact that the patient cried is just a simple fact, and it can literally be a 2-word sentence: patient cried. And don't overthink it. And I would say don't overthink it with all of those observable type things. And yes, they are relevant to document. They are often related to diagnoses or symptoms that someone is experiencing, or reactions to things that someone is processing, to events that someone is processing. So, they're very relevant details that I would not recommend leaving out. You can also use that as a gauge for client progress. So you may have clients who rarely cry, for example, and maybe show anger instead. And then, after some kind of a breakthrough, they're actually able to cry about a situation and describe their sadness or grief around it, rather than focusing on what might be a more comfortable behavior for them or emotion for them, right? On the flip side, you might have someone who is very sensitive and is crying a lot and actually is uncomfortable by that fact, right? Because maybe they become tearful often and it's somewhat embarrassing and they don't want to cry in a work setting or something like that. And so it may, perhaps it's some type of significant trauma someone experienced. And so the fact that they're able to discuss something or go through it after the, weeks or months of therapy without crying, again, is relevant. So as far as the meaning behind it, the relevance behind it, I would say, make sure that that also is based on fact and your experience and the experience with this particular client, because it can mean very different things. But don't overthink it. Just patient cried. That's all that needs to be said. All right, so those are the 3 most commonly Googled questions consistently over and again, month over month, that lead people to the QA Prep website. So let's get into your questions here. Feel free to type any of your questions in the chat. We do have one from Joe, so thank you for asking. And that is, how long should an initial intake session note be? Should it be a report including all history, symptoms, social history, abuse history, etc.? Joe, this is a great question. And I do address this in a recent video on intakes. I cannot remember the name of it, but I will link to that in below in this video, in the recording. So an initial intake session note. So to me, there are two things here. You're kind of describing two separate things. There's an initial intake assessment that happens, which is both a practice that we do, right, of actually gathering data and talking with people, and also a form, typically, because it's a lot of information and it's usually too much information for us to just remember. It's stuff that we want to have documented. So that intake assessment form is a form, and that is something that I recommend you have clients fill out. To me, there is no reason for you to spend all of your time in an intake session completing all of that documentation. It's much better if the clients fill it out ahead of time. You get to read through that form in the client's own words and see how they phrase things and what they prioritize. And then the form is already done. And then you get to focus on just pinpointing things that perhaps you want more information about or things that are more relevant to the actual treatment with you. So, because there are a lot of kind of background informational things we gather about clients that may or may not be relevant to treatment later. So it's really, really helpful, saves you a ton of time, and actually helps you to build rapport more easily and get through the paperwork stuff in an intake session and just focus on what's important to the client. So if you use that format, the things like you mentioned, like history, symptoms, social history, abuse history, all of that, education, occupation, all those things would be in that initial intake assessment. Now, you're going to write a progress note for that first intake session. So that's going to be your intake progress note. And that is simply saying, hey, we did that intake assessment, right? So that intake progress note is going to be longer than your typical progress note. And I do recommend having a separate intake progress note template from your other individual therapy note templates. But in that note, you're simply explaining what you did. So you're putting in things like we reviewed limits to confidentiality, we discussed payment, we, reviewed when I have to report things. They signed the policies and procedures. I have a whole like checklist for my intake note templates that have all of those things. Then completed the biopsychosocial form. So that's like that intake assessment form, whatever it is you call it, completed initial intake assessment form. You simply write that you did all of those things. And then you'll also include things like your mental status exam because it's your first time seeing that person, your diagnostic impressions, especially if you are going to be billing to insurance and you'll need to provide a diagnosis. So you want to provide some justification for that initial diagnosis. And any plan. So did you actually talk about a treatment plan, or do you plan to do that in the next session? Is the initial assessment done? Are you following up on that next session? Do you have preliminary goals set? All those kind of things that you talk about with people in an initial session. That's what's going to be in your intake progress note, not all the nitty-gritty details about their family history and who lives at the house and all these other things. So hopefully that helps. Let's see, Chandra has a question which says, how do you document when an adult patient states they are suicidal but doesn't appear sad? They are very matter of fact. Yes, I've experienced this as well. And I would simply put, client reports and then whatever their suicidal statement was, right? So client reports, I thought about killing myself last night. Client reports, I'm planning to go drive off a bridge after this session. Client reports, I feel like I don't want to live anymore. Those are various degrees of suicidal statements, right? So you want to put that specific statement that they say in quotes in that note. Because the degree of the statement does matter, right? There are lots of times we talk with people who say, I don't feel like living anymore. And that, depending on the conversation you have with them, that may lead to them being in the hospital. It may not, right? There are people who kind of live with a consistent passive suicidality at different points in their depression. And then there are people for whom that statement would be much more significant as far as meaning they're at a different level with wanting to take action on that suicidal statement. So I would say literally just, especially anything where it is like high risk stuff. So if it's things like a reason you had to make a child abuse report, which is breaking confidentiality, if it's reasons for having to, hospitalize someone, or reasons for explaining why you aren't going to hospitalize someone, or whatever action you're planning to take regarding a high risk situation with a client, this is where quotes are the best option. Don't leave it up for interpretation, just simply state the fact. Now, you can also state the incongruence, right? And sometimes that incongruence could be due to that particular client. So I have talked with uh, people with schizophrenia, for example, who have a very flat affect but are talking about feeling suicidal. And that's very different from talking with someone who maybe is dealing with a significant depression and really doesn't have much history of significant depression and now is feeling suicidal. They will tend to show much more emotion around it. It doesn't mean that one or the other is more or less likely to actually act on that statement, right? So this is where it's important to document the statement and then document your assessment of that statement and the follow-up afterwards. And that can also be based on your knowledge of the client. That's going to be very different if it's your first time seeing this person versus if you've been working with them for 6 months and tend to know them fairly well, right? So for example, if this is someone you know really well, and they make that statement and that's really normal for them to, not show their sadness. You may be feeling that that's a really important statement, or this could be someone you see again, have seen for months and months, and they make very similar statements consistently and don't show emotion, and so that is maybe less of a risk because it's kind of more of a way in which this person is showing their depression actively and something you're actively assessing and talking to them about. So it's, anything with high risk stuff is always going to be a gray area. Trust your gut as far as what to document. Document more rather than less because you don't want questions about both what you did or why you did what you did. So that's what I would say. But absolutely document the incongruence. And that's really anytime you see incongruence with how someone is presenting and what they're saying. And oftentimes we will literally, as therapists, point that out to people, right? So you say this, and yet you appear this way. Can you tell me more about that, for example? So I would document the follow-up there. Great questions. All right, so let's see. Ferris has a question. Hopefully I'm saying your name correctly. Taking a refresher course in psychodynamic therapy where if done in a purist way, goals are a little more vague, interventions less so. Any thoughts about documenting with such a style of therapy? Another excellent question. So again, with psychodynamic therapy, it's not that you have to turn documentation into CBT language. Here, again, I would use a lot of your client quotes. So clients may tell you, as far as goals, oh, I want to feel better. What would that look like? What does feeling better look like for you? Regardless of the type of therapy you're doing, that's a relevant question because how are you going to measure that? How are you going to know that's happening? That is something that is useful and helpful to explore with people. So I would kind of walk them through, painting a better picture for you of what their goals look like. You can keep those goals fairly, vague or based on things like exploring emotions, having goals around like exploring or processing emotions or traumatic events or past experiences, all work fairly well with psychodynamic type of therapy. And you can word those in a way that actually will still work with insurance. If you're not working with insurance, it's really less of a big deal. You don't really have to worry about it quite so much. But I do still think it's helpful for clients just because I know in my personal life, like talking with people who have been to therapy and, many, many people actually, it's really common that I hear from friends in my personal life that they felt like at a certain point their therapy kind of stagnated and that their therapist wasn't doing much and that they didn't really know like where the therapy was going or what was happening. And often I would recommend to people, well, talk to your therapist about it, right? Like therapists are totally open to talking about that and want to hear that from you. But clients often feel uncomfortable doing that because it feels that's I think where the hierarchy in the relationship often comes into play. So bring it up with people and let them know, hey, I want to understand what that means for you. I want to understand what that would look like and how you would know that therapy is working well. And you can do that, especially with psychodynamic therapy, within the context of maybe saying like within a year, right? So looking a little bit more long term at what type of progress might be made. So that would be my recommendation. And really, as far as so this is my only, this will be like a hot take, I guess, on my stuff with psychodynamic therapy, and this relates a lot. I think this has an impact on our profession because it relates to a lot of questions I get from people about progress notes in particular, which is that the emphasis is so heavily on interventions, um, and yet we can intervene and do all these awesome interventions and have all this clinical sounding language, and we can do that. And if someone is simply showing up for an hour a week and only doing that and really has no investment in the therapy, we know that the therapy is not very successful, right? What really helps is that relationship with the therapist and that the client is also motivated. And so, that's when the best therapy happens, right? Um, so and a lot of insurance is less interested in what you're doing and more interested in the progress the client is making. So that can be helpful to remember because I think most therapists become really uncomfortable or lack confidence around how they phrase interventions and how they word things and how they talk about it. And really, from an insurance standpoint, yes, you want to have you know clinical interventions. There should be things that you're doing that someone's grandmother could not do for them, right? There should be a reason you had to go to training. So kind of think through, as far as with the psychodynamic training, like what is it you're learning in this training to offer people that you could not have done on your own, right? Especially like being a therapist, we typically have a certain type of demeanor and are interested in people and like to talk with people, like to help people. But what did you need to go to grad school to do? Those are the type of things you put in your progress note. But more important in your progress note is the impact of the therapy on the client. And so, how is the client progressing or not progressing, which is also fine to put. But how is the therapy impacting the client? What is the client's response? How are they reacting to things? What are they doing outside of sessions? Those are all things that are actually more relevant and really easy to talk about because you're just stating facts. Again, to kind of go back to that question about how to document a patient crying, it's just a fact, right? That they cried. And now I do encourage you to go into the meaning behind it, obviously, but the fact that they cried just it's an observable fact. So a lot of things that you can document about your clients, it doesn't have to be something you're super concerned about happening or sharing too much information. It's just a fact of what happened in the session. So I think hopefully that takes a little pressure off for a lot of people because that is where I find the most not hesitancy, but I think the most like for lack of a better phrase, like lack of confidence around notes is interventions, and it's much more important to focus on the impact of therapy on your client. And that, I would say, is regardless of whether you're psychodynamic or CBT or whatever, truly what our goal is, right? And actually asking your clients about it can be really, really helpful as far as documenting that. All right, so we'll do one more question from Kim, and then we will sign off so that we don't have a video that lasts super long, but we will be doing another YouTube live next week. Spoiler alert. So Kim asked, what might be a good way to phrase so much of what we do, helping clients clarify and process that would be acceptable to insurance? Yes. So if you check out last week's video, which is 23 therapy interventions, as a part of that, and I will link to that in the recording underneath here, and if you go to that video, there is a link to download a handout that has 23 therapy interventions that you can use. And it is a lot of these things. So I would guide you to that. I think the name of it is 23 therapy interventions or something like that. If you type that in, you will absolutely find it. So download that. You can use that as a cheat sheet. It's I think, a great cheat sheet to use for therapy and will cover most of what you do most of the time. And that's a lot of when you're clarifying or processing with people, it's okay to say that you explored emotions, that you processed emotions, that you processed an experience, that you explored how an experience is impacting a current behavior or a current emotion, right? Um, and so using, like, literally using those type of phrases, I think is the most helpful. Um, and saying, what is it that you help them clarify? Helped client clarify, etc. Right? So maybe you helped them clarify um, goals for their relationship. Maybe you helped them clarify why they get anxious when they go to family events. Maybe you helped them clarify how to communicate a problem with another person, right? So there is a lot of kind of, I think you're talking about kind of this behind the scenes type stuff. Um, and here's a general rule too. I think sometimes this can feel uncomfortable because we feel like we have to write. Again, it's like I notice therapists feel like we have to write so much to justify what we're doing, right? In the progress note. And you really don't. 3 to 4 therapy interventions are fine. Download that 23 interventions list. Um, and you will absolutely look through that list after you do a session and be like, oh yeah, I did that. I did that. I did that. And in that video, I give you, and in the handout, I give you examples of how to use each intervention too. So that kind of gets you started with how you can apply it. Um, so that's what I would guide you to. But yeah, don't worry so much about how, trying to justify what it is that we do. It's okay to explain the process. Yes, do consider insurance. I think it's really helpful that you're doing that for your clients. Um, and I really appreciate when a lot of therapists who are more psychodynamic oriented or who are doing more long-term work, are mindful of the fact that you want your clients to be able to use their insurance. So major props to all of you out there doing that. And hopefully the resources I'm giving you make that a little bit easier. All right, we are going to sign off. I will go ahead and link those other videos after the recording is done processing, and I can set all of that up. Thank you for those of you who were here and asked questions. Awesome, awesome questions, and so relevant to what we were talking about today. So we will see you all next week. Happy writing.